our senior consultant psychiatrist, and with the main area of interest in suicide as well. So today the topic is a very important topic, but perhaps we have not spoken enough about it, but still very relevant to our clinical practice, not only for psychiatry, but as well as, I think, maybe such case can be presented as medical emergency as well, as you will find in the discussion as well, yeah? So the topic is entitled as Designer Drugs, Vaping and ADHD. What's the deal? So without further ado, I would like to invite Dr. Chiara Petrus to start the ball rolling and present the case that's going to be based on for the further discussion. Okay. Please welcome Dr. Chiara.
Thank you, Prof. Ning. Good morning, professors, doctors, and everyone present here today. Let's begin with the clinical history about our case today. Mr. R is a 21-year-old single Punjabi gentleman. He works as a stock market trader and lives with his parents in KL. He was brought to our emergency department for aggressive behavior of 1-day duration via an ambulance. He was initially brought to a private hospital, but due to the inability to sedate him for aggressive behavior with 10 milligrams of IM haloperidol, 10 milligrams of diazepam, as well as needing 10 people to hold him down, so he was then transferred over to our facility. Besides the aggressive behavior, he had persecutory delusions for 1 day. He believed that his uncle had wanted to rape him. He believed his mother wanted to harm him, despite her only gently touching his hand in the emergency department. And this led to him being very physically and verbally aggressive. He also had auditory hallucinations for the past 3 weeks, basically and mainly hearing the parents of his voice in the third person talking about him, and they were not present in the room. This occurred in clear consciousness, and he could not control it. It came from an external source, and this left him feeling very anxious. His mother also observed him talking to himself, arguing with voices that only he heard. She could not hear any of those voices at the time that he was speaking, and he would also answer irrelevantly to her questions at times. Besides that, he had visual hallucinations for 3 weeks. He could see his hands detached from his body, and these hands were moving around the house. He also had color distortion, seeing things around him in the hues of red, green, and yellow. Mr. R began using synthetic tetrahydrocannabinol, THC vape, about 1 month ago, prior to his presentation. He used to smoke marijuana leaves, but he switched to vaping it, and then he further switched to synthetic use of this particular THC to see as a way to test the differing effects that the synthetic THC had. He was also attracted to synthetic THC because it was easy to conceal, thinking that it may not be detected in the urine, as well as it being easier to use and odorless. He knowingly purchased 3 ready-made vape vials from an online drug dealer for 100 ringgit, and each vial contained about 10 ml of solution to be used in his refillable vape kit. He consumed one vial in the past 1 month. So for the first week, he would vape about every 3 hours in a day, and he felt that he could concentrate better, and he felt this high. And so he increased it to every hour because of this instant high effect that he got. His last use of synthetic THC vape was 2 days prior to his admission. Within the first 2 weeks, he attempted to gradually reduce the synthetic THC vape, and this was because of the auditory hallucinations that caused him to feel very anxious all the time. He had low mood because of this, he had poor appetite, and he eventually lost about 5 kilograms in that past 1 month. He had poor concentration. His productivity was affected. He usually would work about 5 days per week, but this time he could only work about 2 days. And by the 3rd week, he completely stopped vaping for a few days, but this led him to be very irritable, very verbally abusive. He got, especially towards his mom, which is unlike of him. He also experiences restlessness, whereby he would be pacing around the 2-story bungalow house, even non-stop daytime and nighttime. And he had sleeping difficulties. He found it difficult to initiate sleep as well as maintain the sleep. Usually he can get about 6 hours, but this time he would get 2 hours and feel a bit tired after that. He resumed vaping the synthetic THC on and off to alleviate these symptoms. For his past psychiatric history, he was diagnosed with ADHD at the age of 14 years old in Singapore, and this was after increasingly disruptive behaviors that was already present in his childhood but kind of escalated to the point in secondary school, and that's when they sought for help. He was started on tablet Concerta that was escalated to a dose of 72 milligrams, and he could feel his concentration improve when he was on Concerta, although it lasted only about 20 minutes. However, his compliance to this Concerta gradually decreased as his concomitant substance use increased. And he completely stopped taking his Concerta by the age of 18 years old because he felt that it reduced his social drive and he had anhedonia. And since stopping his Concerta, he had trouble concentrating, he became more impulsive, as also evidenced by his escalating drug use, and he drove recklessly to the point that his parents would need to employ like drivers, curfews, just to ensure his safety. He coped with his symptoms by exercising daily in the gym, and this also caused him to believe that it would offset the side effects of his vaping habits. He experienced intermittent depressive symptoms twice. The first episode was when he was about 13 years old. This was after he was sent to boarding school in the UK. He had low mood, suicidal ideations. He could not recall much about this episode. The second episode was when he was at the age of 17 years old. Similarly, this began when he went to the UK to begin his bachelor's degree, and his polysubstance use had also escalated. And attempts to cut down on this substance use led him to experience these depressive symptoms of low mood, loss of weight, appetite, sleeping difficulties, poor concentration, and this was intermittent. So he coped with these symptoms by continuing the use of his cannabis. He did not seek any treatment for these episodes. As for his family history, he's the oldest of two children from a non-consanguineous marriage. His father is a 62-year-old renowned Tan Sri in the Malaysian stock market trading industry. His mom is a 53-year-old master's graduate. She's an English literature lecturer and tutor. She has ADHD, but she's not on treatment. She copes by doing yoga. The sister is 15 years old. She also displays symptoms highly suggestive of ADHD, but she's not on treatment as well. There is also a family history of alcohol use disorder in his paternal grandfather, bipolar disorder in his paternal cousin, and ADHD in his mom. As for his personal history, he was born term spontaneous vaginal delivery. Antenatally was uneventful. Intrapartum, he sustained 3 hematomas on his head. This was due to prolonged second stage of labor. He was discharged from the NICU after 1 week. He was exclusively breastfed until the age of 2. And as for his milestones, he began to speak 3-word sentences at the age of 12 months, and he could walk independently by the age of 13 months. There were no childhood illnesses or health issues. As for his schooling, he began play school at the age of 2.5 years old. He attained a black belt in Taekwondo at the age of 10, and he consistently scored more than 92% in his primary school despite minimal time invested in his studies. He had an above average IQ score in the Wechsler's intelligence scale, and this was done as part of his ADHD assessment. He was privately educated and completed his IB with the grade 6. So the maximum grade is 7. He obtained grade 6 at the age of 16 years old. He had frequent disciplinary issues throughout his primary as well as his secondary school, and this was mostly attributed to his ADHD symptoms. At the age of 17, he began his degree in Applied Economics and Business Management at the University of Exeter, and he completed 3 semesters with the lowest score of 72%, and this was affected by his polysubstance use. He decided to discontinue his studies due to boredom, loss of interest. He found the subject matter very unchallenging, and so he transferred his credits back to Malaysia. He continued here at Monash, Malaysia, but after 1 semester, he dropped it completely. Moving on to his substance history, he began smoking nicotine at the age of 13 years old. He would smoke initially 3 sticks, and he found it relaxing and it helped with his sleeping difficulties. And so he began vaping nicotine at the age of 14 years old, initially at 6-hour intervals, but he escalated it to 3-hourly. He spent about 20 ringgit per week on vape, and efforts to cut down left him feeling very restless, irritable, and having sleeping difficulties. His persistent use of nicotine in the form of vape was rationalized by his exercise regime being able to offset the damage. He also began using ketamine. This was when he was in the UK. He used to snort it in the powder form, about 1 gram per week. And he achieved the desired effect of the calming effect, and he also experienced dissociation. He quit using ketamine because he found that it decreased his motivation to socialize. His substance, besides that, he has a history of taking LSD, and he started this at the age of 14 years old, and this was out of curiosity. And he started by taking it sublingually via blotted paper, 150 micrograms per use, and it was in infrequent usage. The hallucinogenic effects would last him about 6 hours, whereby he would experience color and sound alterations. And his last use was about 3 years ago, back when he was in the UK. He's also tried magic mushrooms, psilocybin. This was similarly at the age of 17 years old when he first went to UK. He would take about 3 fresh mushrooms per use. Each mushroom is 1 gram. And the hallucinogenic effects, similarly like LSD, would last him about 5 hours per piece. And he stopped this in 2021. Next, he had also tried MDMA. He began this at 17 years old, similarly in the UK, obtained by drug dealers that were easily introduced by friends. He took it in tablet form and also snorted it in a powder form, and he sought its uplifting effects. The total intake would be about 2 grams per consumption, but this was infrequent. His last use was about 2 years back. For his alcohol history, he began consuming alcohol at the age of 13 years old. Initially, he would start off with beer, vodka, and tequila. He drank socially by the age of 17 years old, whereby every weekly, mostly on the weekends, he would be out drinking with his friends. At least 12 units of alcohol would be consumed each time he went out, and he binge drank about twice a month. He would drink until he got drunk. He would be getting into fights, picking up girls at the bars. He desired the euphoric and the drowsy effect it had on him, and he never had a period of abstinence. He denied having withdrawal symptoms when he was not on alcohol, and his last drink was 3 days prior to admission, whereby he had 4 cans of beer with his friends. As for his occupational history, he was a bartender for about a month upon the completion of his IB diploma, and he began full-time trading last year in 2023. This was after he came back from the UK and decided not to continue with his studies in Monash, and he achieved a 25,000 profit since then. He is yet to be financially independent, mainly supported by his parents. As for his pre-morbid personality, which was described by his mother, he was arrogant, enjoyed being the center of attention, he has a strong sense of entitlement, he exaggerates his investing achievements despite the inability to self-sustain himself, and these symptoms likely point to narcissistic personality traits. The mental status examination that we did for him, this was upon his arrival to our ED, our emergency department. He was a tall, muscular gentleman who, despite maintaining good personal hygiene, had unkempt shoulder-length hair. He had a large tattoo across his chest, which was visible through the unbuttoned top segment of the hospital attire that he was clad in. Though cooperative, he exhibited restlessness, he had intermittent eye contact, and had superficial rapport. He appeared to be looking around the place suspiciously. He spoke in fluent English, his speech was irrelevant at times but coherent, and he spoke with a normal tone, rate, amount, and volume. His mood was euthymic, and his affect was broad and congruent to his thoughts with no lability noted. His thought flow was of normal tempo and continuity, with neither thought block nor perseveration observed. At times, there was some thought derailment. There were no forms of delusion, no obsessive-compulsive thoughts, and no suicidal thoughts. We could not elicit any broadcasting, insertion, nor with thoughts of withdrawal. He did not have any hallucinations. As for his cognitive function, he was oriented to time, place, and person. His memory, immediate, recent, remote, as well as his 5-minute memory recall were intact. His attention was intact, he was able to perform the serial 7 subtraction test, and his knowledge and intelligence was appropriate to his level of education. His abstract thinking was intact, and he was able to decipher the meaning of proverbs. His judgment was intact. He had poor insight though. He was not acknowledging his illness. He was not keen to take his medicines for his ADHD symptoms, as he considered that he was well and healthy. And he relied on smoking and physical exercise to manage the symptoms, despite acknowledging the side effects and the reality of his condition. As for his physical examination, he was conscious, not in respiratory distress. There was no redness in his eyes seen in the emergency department. His vitals were stable except for his heart rate was slightly tachycardic. His physical examination of all systems, including his neurological system, were unremarkable. For his laboratory investigations, generally it was unremarkable except for some leukocytosis, as well as some a mild elevation of his free T4, which we are planning to repeat in about 3 months' time. As for his urine drug screening, it was positive for benzodiazepines, and this was likely due to the IV diazepam that was given to him at the private hospital prior to his transfer to our hospital. This is the non-contrasted CT brain that we did for him. From this rapidly fast video, we can see that there's no significant abnormalities detected as per reported by the radiologist. So our diagnosis for Mr. R is synthetic cannabis use disorder with onset during intoxication, with comorbid ADHD of combined presentation with severe severity, cannabis and nicotine use disorder, as well as polysubstance use disorder and alcohol abuse. He was given another 10 milligrams of IV diazepam at our emergency department about 15 hours after his presentation. Another 1 milligram tablet clonazepam was served to him the night as well as the next morning. He was discharged after 1 night of admission as he had calmed down and family were very keen to take him home. He was prescribed tablet atomoxetine 40 milligrams once a day, and he was referred to the quit smoking clinic at Primer Clinic upon discharge. However, the patient did not take the prescribed medication, nor did he attend the quit smoking clinic program despite being given a date. And there were multiple psychiatric consults that were done face-to-face via teleconsultation, including family sessions. This was done with the hope to build insight to him as well as to, just to build a rapport and try to get him to be more open and receptive to the treatment. However, he remains steadfast in his wish to not receive any pharmacological or non-pharmacological interventions. And so we have kept the option of restarting medications, referrals to the quit smoking program, occupational therapy for the ADHD. We've left this door open for him in the future, should he see the need to, or if he experiences any depressive episodes in the future. Thank you.
Thank you, Dr. Chiara, for a very clear, concise presentation.
Good morning.
Okay. Maybe we keep the questions all at the end of the session. And the second presentation is about drug of abuse in e-cigarettes by Dr. Rashidi Mohamed, Pakri Mohamed. Unfortunately, he cannot join us, but he has provided us this video. So we're going to switch this on and going to learn a bit more about the drugs that are more popular these days. Yeah. Sorry. How do we do this?
Good morning, everyone. I'm Dr. Rashidi Mohamed, Family Medicine Specialist from the Department of Family Medicine. We will continue our CPC presentation today with drug of abuse in e-cigarettes. It is a growing public health concern as emerging drugs of abuse using e-cigarettes and vape is becoming more and more rampant. These devices, originally marketed as a safer alternative for cigarettes, has become a popular way for people to consume a variety of substances, which includes nicotine, marijuana, and even synthetic drugs. In this presentation, we'll explore the trends, dangers, and potential solutions around this issue. E-cigarette and vapes are battery-operated devices that heat up e-liquids to create an aerosol for inhalation. E-liquids typically contains nicotine, propylene glycol, vegetable glycerin, and also flavoring. Initially, it was promoted as a less harmful alternative to cigarettes. Their long-term health effects are still under investigation. However, a disturbing trend has emerged as they have been used to inhale illicit drugs. These are the types of electronic nicotine delivery systems. They are the cigar lights, the pod kits, vape pens, and also box kits. Briefly, we will talk about the Control of Tobacco Product and Smoking Bill 2022, which is also known as the Generational Endgame. The bill was aimed to create a tobacco-free generation by prohibiting individuals born after a certain date, often cited as 1st January 2007, from smoking or possessing tobacco products. The proposed bill was to ban the sales of cigarettes and other tobacco products to people at this age cohort. The proposed penalties for violation were initially set at a maximum fine of 5,000 ringgit, but were later reduced to 500 ringgit or community services. However, this bill was not passed into law due to the dissolution of the Parliament for election. A revised version was introduced in June 2023, but then was later withdrawn in November 2023. Undang-Undang Kawalan Produk Merokok Demi Kesihatan Awam 2023 was later introduced, and it has been found to be more comprehensive as the previous bill. The use of e-cigarette and vape among Malaysian teens aged 13 to 17 is concerning, as the prevalence has increased from 9.8% in 2017 to 14.9% in 2022. The overall prevalence in Malaysian adults of using e-cigarettes is 3.2% in a study done in 2016. Although e-liquid typically contains nicotine, propylene glycol, vegetable glycerin, and flavorings, they can be laced with other substances, which includes THC, which is a psychoactive component of marijuana, synthetic cannabinoids, and even opioids. This can be done with or without the knowledge of the user. This is a concern because the long-term health effects of vaping are still unknown. Vaping can expose users to harmful chemicals, including heavy metals, volatile organic compounds, and ultrafine particles. The use of vape to consume other drugs can lead to addiction, overdose, and other health problems. Teen and young adults are especially vulnerable to the dangers of vaping, as their brains are still developing. In a study conducted by the CDC in 2021, it has been reported that 1/3 of young adults who vape reported using THC-containing products. THC, the psychoactive component of marijuana, can impair the brain development of teens and young adults. Regular use of marijuana can lead to addiction, respiratory problems, and mental health problems. Vaping marijuana may expose users to higher levels of THC than smoking marijuana. Substances which has been documented used in e-cigarettes and vape includes nicotine, synthetic cannabinoids, fentanyl, methamphetamine, cocaine, and also CBD. These can lead to complications such as lung damage, addiction, increased risk of psychosis in the THC and synthetic cannabinoid use, and impaired brain development. Although e-cigarette and vape was introduced as a safer alternative to smoking cigarettes, we have found more and more cases where patients coming in who wants to quit e-cigarette and vape because of the addiction towards the vape and e-cigarettes. Unfortunately, there aren't any currently approved medication specifically for e-cigarette addiction, but there are other effective strategies which we conduct at our clinic. This includes behavior therapies such as CBT, motivational interviewing, and also support groups. Although not specifically designed for e-cigarettes, nicotine replacement therapy like patch, gum, lozenges, and spray can help manage withdrawal symptoms by delivering a small amount of nicotine. And we have found that combining behavior therapy with NRT can be more effective than using either method alone. For patients who want to quit e-cigarette or vape use, develop a quit plan, set a date, identify triggers, and plan how the patient will cope with the craving. We should avoid triggers, recognize situations or emotions that can crave e-cigarettes. Tell family members and friends, find healthy activities to replace e-cigarette use, such as hobbies, exercise, and so forth. Seek professional help. That's what we tell the patients. Don't be afraid to seek guidance from a doctor, therapist, or smoking cessation specialist. And be patient because quitting an addictive substance takes time and effort. At Clinic Primer, we have our Quit Smoking Clinic and Addiction Clinic. We have a dedicated team for patients who have been referred to us to help to quit smoking, vaping, and also some other drug of abuse. In our Quit Smoking Clinic, it is either individual or group therapy, and we have either face-to-face and also virtual consultation to help smokers to quit smoking. And following introduction of the virtual consultation, we have managed to improve our attrition rate and also keep our patients in the follow-up. With this, I conclude my presentation on drugs of abuse in e-cigarettes. Thank you very much for your kind attention.
I believe that is very, very informative, and it is very disturbing as well to know that vape can be used as a medium for illicit drug use, and the presentation can be very complex as demonstrated by this case. So to discuss further about this case, I would like to invite Professor Dr. Chan Lai Fong to present the discussion. Yeah, there is an overview and discussion as well. Yeah. Please welcome.
Thank you a lot, Prof. Nick. Just give me a moment to set up. A very good morning to everyone. It's great to see the medical students and lecturers here. I'd just like to continue from where Chiara left off. So Chiara gave a rather long provisional diagnosis of synthetic cannabinoid, induced psychosis during intoxication with other polysubstance abuse. But to be frank, when the patient presented first to us without the extensive history that we managed to obtain later, when we saw the patient for ourselves in the ward, when the patient was presented in grand ward rounds, there was actually the working differential of schizophrenia spectrum disorder. So this just goes to say that even with substance-induced disorders, they can actually very much present like schizophrenia, and we have to take a very careful history and mental state examination as well as physical examination to actually come up with the correct provisional diagnosis. Let me just try and move this. Okay. So in terms of overview, I'll touch about what is new psychoactive substance, or another term that Dr. Rashidi used is emerging substance of abuse, synthetic cannabinoid receptor agonist, molecular mechanism of cannabinoid receptor, effects of synthetic cannabinoid receptor agonist, ADHD and polysubstance use disorder, referring to synthetic cannabinoid and nicotine vaping, the epidemiology, genetic and environmental risk factors, treatment modalities and challenges, policy implications for NPS and e-cigarettes. So I'm going to introduce the concept of NPS and synthetic cannabinoid as an example of new psychoactive substance. Synthetic cannabinoid receptor agonist is the second commonest NPS currently worldwide. Now, NPS refers to substances that mimic the effects of controlled drugs such as cannabis, cocaine, ecstasy, methamphetamine, or heroin. They are produced by introducing slight modifications to the chemical structures of existing NPS and controlled drugs to create new variations that are not yet controlled. NPS are usually marketed as legal highs, quote unquote, as they may yet to be controlled by the authorities, which gives the wrong impression that they are safe to consume, although they are not. On the contrary, NPS are illicit in nature and are known to be abused recreationally, clandestinely manufactured, and associated with overdose fatalities or adverse reactions. In Malaysia, synthetic cannabinoids are the most common NPS. Policy-wise, synthetic cannabinoids, some of them, the names are really long, things like ABCHMINAGA, and so on and so forth. Now, these are controlled under the first schedule of Dangerous Drug Act as of January 2019. But this, I just wanted to flash up this particular study because one of the synthetic cannabinoids detected in this study, 5-FADB, was controlled. However, XLR11 is still not regulated under any Malaysian regulations. So it is hoped that this particular study that the authors did could provide useful information for Malaysian legislation authorities in making decision on its control in the future regulations synthetic cannabinoids. So it's kind of like playing a catching up game where there are newer and newer new psychoactive substances, but our regulations are yet to catch up with it. Now, what are synthetic cannabinoids? Synthetic cannabinoids or synthetic cannabinoid receptor agonists is the name given to a diverse range of substances that act on the same brain receptors as tetrahydrocannabinol THC, the main psychoactive substance in cannabis. Typically, synthetic cannabinoids are sold as herbal smoking mixtures. Synthetic cannabinoids have also been distributed as powders, tablets, and products that look like cannabis resin. In recent years, new dosage forms, including e-liquids for vaping, such as used by outpatient, using electronic cigarettes, as well as paper impregnated by synthetic cannabinoids, have appeared on the drug market. Now, this is just showing the molecular mechanism of a synthetic cannabinoid receptor agonist. Interactions of synthetic cannabinoid receptor agonists have been described with dopamine, serotonin, and glutamate systems, with possible effects on schizophrenia and psychosis after SCRA intakes. So patients who are at risk and have genetic history and are predisposed to schizophrenia, synthetic cannabinoids can theoretically precipitate an episode of schizophrenia-like disease as well. Due to the distribution of cannabinoid 1 and cannabinoid 2 receptors on the terminals of neurons, which mediate a modulation and inhibition of synaptic transmission, cannabinoids have effects on neuronal development, motor function, cognition and memory, appetite, sleep, thermoregulation, analgesia, reward processes, cardiovascular, respiratory, immune, and reproductive functions. A wide range of serious physical health harms are associated with synthetic cannabinoid use. They have been reported. These include convulsions and seizures, rhabdomyolysis, hyperemesis syndrome, supraventricular and ventricular arrhythmias, pulmonary embolism, intracranial hemorrhage, delirium, and multiple organ failure. Serious mental health harms include paranoia, psychosis, aggression, and violence towards others, as demonstrated in outpatient, self-harm, and suicide. Synthetic cannabinoid use has also been associated with white matter abnormalities in adolescents and young adults, which may lead to cognitive impairment and vulnerability to psychosis. Intense psychological withdrawal symptoms after use have also been described, leading to a high addictive potential for synthetic cannabinoids, where users have been reported to use synthetic cannabinoids every 30 minutes to avoid feeling unwell. Now, this is kind of like a jigsaw puzzle that we're trying to put together that has been shown in this patient. Here with ADHD in the middle, with many cards stacked against him as predisposing factors to develop the synthetic cannabinoid abuse. Now, genetics-wise, mother was likely to have undiagnosed ADD, paternal cousin bipolar, father was a smoker and alcoholic drinker, with paternal grandfather likely being an alcoholic. Now, let's shift gears a bit and focus now on ADHD, which our patient also has as a comorbid disorder. ADHD is one of the most common neurodevelopmental disorders of childhood. It is usually first diagnosed in childhood and often lasts into adulthood. Children with ADHD may have trouble paying attention, controlling impulsive behaviors, may act without thinking about what the result be, or be overly active, demonstrated in this patient. Now, as we've mentioned, ADHD is a highly comorbid condition, and substance use disorder is possibly the most common comorbid condition with ADHD, particularly with alcohol and or nicotine, cannabis, and cocaine use. Our patient has all of them except cocaine. Substance abuse or dependency is approximately twice as common in individuals with ADHD as it is in the general population. There is a particularly strong association with ADHD and cigarette use, with these populations demonstrating stronger physical dependence to nicotine when compared to individuals without ADHD. The association between ADHD and substance use disorder is bidirectional and stems from various factors. Other comorbid psychiatric disorders, behavioral characteristics such as novelty seeking or impulsivity. In our patient, out of curiosity, under peer influence, he experimented with drugs and attempts to self-medicate ADHD symptoms. In support of the latter, individuals with ADHD more frequently report the use of substances in order to manage their mood as or sleep aids. As in this patient, when he was in his university years, it helped to lessen his distraction and also help him to sleep. The burden of comorbid ADHD with SUD is substantial. Studies have found that ADHD in individuals with substance use disorder is associated with earlier onset of substance use, increased likelihood of suicide attempts. Our patient didn't have a suicide attempt but had suicidal ideation, more hospitalizations, higher rates of polysubstance use, less likely of achieving abstinence, and lower rates of treatment adherence. Overall, the co-occurrence of ADHD and substance use and psychiatric symptoms and outcomes. It is therefore important to screen for ADHD in patients presenting with substance use disorder and vice versa. Now, even though this patient did not develop a full-blown depressive disorder, he experienced some depressive symptoms, including suicidal thoughts during and around the onset of substance, nicotine for sleep issues, and self-medicating use. Similarly, experienced subthreshold depressive symptoms when using synthetic cannabinoids that were transient, and functioning was affected by the psychosis. Now, this paper demonstrates using Mendelian randomization to explore the gateway hypothesis, possible causal effects of smoking initiation and alcohol consumption on substance use outcomes. As we can see here, I find this a helpful way of conceptualizing how actually starting with smoking or alcohol becomes a gateway, using a gateway hypothesis, to using different kinds of or harder drugs. For example, in here, well, marijuana, some people may actually consider is a soft drug, but marijuana really is not without complications and it's not safe. And here it reveals that smoking became a gateway to increase alcohol consumption and cannabis use and cannabis dependence in our patient. Genetics-wise, the paternal grandfather, as mentioned, had alcohol abuse and died of alcohol complications, and the patient had family members who have passed away due to smoking-related illnesses. And ADHD here, of course, is a confounder. Now, practical logistic point view, the availability of vaping vehicle, as Dr. Rashidi has explained in detail, made for easy transition from nicotine to other substances such as synthetic cannabinoid use. Qualitative results revealed that young e-cigarette ever users have higher odds of other psychoactive substance use within 1 or 2 years after baseline measurements compared to e-cigarette never users. These psychoactive substances included stimulants, cannabis, and alcohol, like in our patient. Meta-analytic results showed that young e-cigarette users have 5.15 times the odds of subsequently using cannabis and 6.67 times the odds of subsequently using alcohol compared to e-cigarette never users. Now, it's not all about genes, but also the interaction between genes and environment. Now, as we can see here, this paper on youth vaping, a review and update on global epidemiology, physical and behavioral health risks and clinical conditions. One of the useful clinical screeners questions we can ask is, do your friends or relatives vape, including parents in the house? Because peer vaping is a common entry point and perpetuating factor for adolescent vaping that may complicate quit effects. And parental modeling is important as vaping becomes more problematic among patients with inconsistent parents who do not give a smoke-free environment or vape-free environment. So especially in this case, the father was pretty permissive, and he himself being a smoker, and rationalized e-cigarette smoking as okay after informal consultation with friends who were healthcare professionals themselves. And electronic vaping can actually give rise to very severe physical morbidity, such as electronic cigarette or vaping associated acute lung injury, which can be fatal. So it's absolutely not safe. And now, why synthetic cannabinoids and why in ADHD? The results obtained in this paper showed here that the DRD2 SLC6A2 and HTR2A genes of the serotonergic and dopaminergic systems are predictors for the development of synthetic cannabinoid dependence in individuals with ADHD. In addition, ADHD has been shown to be a good predictor for the development of synthetic cannabinoid dependence. Now, there is actual structural brain changes in synthetic cannabinoid users with ADHD. Now, there is thinner cortical regions in all synthetic cannabinoid users in comparison to controls, thinner cortical regions in synthetic cannabinoid users without ADHD in comparison to controls, thinner cortical regions in synthetic cannabinoid users with ADHD in comparison to controls. So synthetic cannabinoid users both with and without ADHD groups have significantly reduced cortical thickness compared to controls in areas of the left caudal, middle frontal, and left superior frontal region. In addition, synthetic cannabinoid users with ADHD also showed reduced cortical thickness in the right precentral and postcentral gyruses. The paper also found increased right nucleus accumbens volume in synthetic cannabinoid users without ADHD, but not with ADHD compared to controls. In conclusion, these results suggest that similar to cannabis use, synthetic cannabinoid use has also negative effects on brain morphology, and comorbidity of ADHD and substance dependence may show different cortical thickness and subcortical volume alterations than substance use alone. So there is slightly a compounding effect or negative effect on the brain morphology if you have both synthetic cannabinoid use as well as ADHD. Now, there's also structural connectivity in adolescent synthetic cannabinoid users with or without ADHD. We found that synthetic cannabinoid users without ADHD had significantly weaker connectivity compared to controls in bilateral hemispheres, most notably in edges connecting the left parietal and occipital regions. In contrast, synthetic cannabinoid users with ADHD showed stronger structural connectivity compared to controls. It is unclear what these increases in structural connectivity represent. One speculative explanation might be that it is a compensatory reorganization of neural circuit indicative of adaptive or extended neuroplasticity. In addition, adolescent synthetic cannabinoid users with ADHD displayed reduced network organization indicated by lower clustering coefficient and modularity, suggesting that poor structural network segregation and preserved structural network integration. Now, these results suggest that comorbidity of ADHD and substance dependence may show different structural connectivity alterations than substance use alone. Now, how do we treat acute synthetic cannabinoid intoxication? Now, most mild synthetic intoxications only require ambulatory symptomatic treatment. Now, severe intoxications like in our patient, e.g., now our patient didn't have seizures, but patients can have seizures, severe agitation. Our patient had neuropsychiatric perturbations. Other things like arrhythmias, stroke, thoracic pain often lead to hospitalization. Acute synthetic cannabinoid intoxication treatment usually includes intensive monitoring and supportive therapy. Intravenous fluids are often administered to expand the volume of circulatory system, control vomiting, and prevent dehydration and renal failure. Sedation with benzodiazepines, for example, lorazepam, is the first-line treatment in reduced anxiety and agitation. Psychiatric evaluation and antipsychotic administration are often necessary, like in the case of our patient. Intubation and mechanical ventilation may be required in severe cases. Now, recently, this author Eskel et al. Described a new treatment for synthetic cannabinoid intoxication, referring to as intravenous lipid emulsion, ILE, which showed promising results as an effective antidote in poisonings by lipophilic drugs such as SCs, allowing recovery from cardiovascular collapse and reversing the neurological symptoms caused by these drugs. ILE retains drugs found in the intravascular space and distributes the fat-soluble drugs to circulating phase, reducing their concentration and toxicity. Treatment for synthetic cannabinoid withdrawal symptoms is based on benzodiazepines, antiemetics, and other symptomatic care. Now, in terms of non-pharmacological treatment, Dr. Rashidi has outlined the components and principles of his quit smoking clinic. But from literature, there is this particular psychological therapy called integrated cognitive behavior therapy for ADHD in adult substance use disorder, results of a randomized controlled trial. As you can see here, CBT or integrated CBT considered in 15 individual sessions of motivational interviewing, coping skills training, and relapse prevention for SUD, and training of planning skills, problem solving skills, and dealing with emotions for ADHD. If you compare it with CBT for just substance use disorder, which consists of 10 individual substance use disorder treatment sessions only. So the primary outcome in this randomized control trial was ADHD symptom severity and post-treatment. Secondary outcomes included ADHD symptom severity after 2-month follow-up and treatment response, where it's measured by more than 30% of ADHD symptoms reduction, substance use, depressive or anxiety symptoms, and quality of life at post-treatment and follow-up. Now, it showed that CBT integrated was more effective than CBT substance use disorder only in the reduction of ADHD symptoms post-treatment. However, substance use, no significant between group differences were present. So in conclusion, compared to regular substance use disorder cognitive behavior therapy, if you use integrated cognitive behavior therapy, it results in a significant early improvement in ADHD symptoms in substance use disorder and ADHD patients. Now, I just like this diagram because it gives us a way to understand and formulate this particular patient that we have here in terms of perpetuating factors. This is the cycle of change by Prochaska and De Clemente to model the perpetuating factors for maintenance of nicotine vaping. Now, with synthetic cannabis, you would see that he is probably in the action to maintenance phase. No more vaping synthetic cannabinoids, because that actually made our patient lose control. And he rationalized by cardio workouts, negating the negative consequences of nicotine vaping. Now, with nicotine and alcohol, he's probably at the pre-contemplation phase, which he views as not a problem. Whereas for synthetic cannabinoids, he views it as losing control, which he doesn't like, and that actually was very traumatic for him. But for smoking, patient currently refuses quit smoking clinic, referral to family medicine specialist clinic. He feels there's nothing to change. And in terms of the environment, there is over-scaffolding from the family for compensating for his ADHD. For example, if he loses his keys, instead of helping him with memory aids or try to come up with structural ways to actually help him remember where to put his keys, they just get a driver because they have the means. So inconsistent parenting, permissive father enables the nicotine addiction and social modeling as well. And the patient's narcissistic trait fuels the addiction denial that there is no problem at all. The sense of invulnerability to the longer-term consequences of vaping, nicotine, and drinking perpetuates the abuse of these substances. In the ideal event, we could use motivational interviewing, yet the therapist might face challenges including tackling ego inflation and narcissistic denial, which are significant recovery obstacles. The therapist's role is crucial in breaking these barriers for effective treatment and healing. So in his narcissistic traits, he is always right. The narrative is that his sense of invulnerability and entitlement that is a barrier for treatment engagement and perpetuating factor for continued nicotine vaping. So the prognosis can be guarded or poor, but it is the modifiable environment and non-modifiable genetics that we have to consider in this case. So our doors are still always open for this patient to come when he actually improves his insight and feels that there is a problem that we can help him with. Now, I'd just like to draw this to a close by talking a little bit of policy implications. Now, besides patient factors, immediate environment factors such as extended environmental societal factors such as policy also have a broader impact as precipitating and perpetuating factors for young people to be initiated into vaping, which acts as a gateway to other substance use like new psychoactive substance. This came out in the newspapers in Star, where it was a bit of a shocker, where the deputy minister admitted that tobacco vape industry actually ended the GEG proposal. If you remember, Dr. Rashidi actually touched on the generational endgame bill, which did not make it to parliament. In parliament, it was openly admitted that tobacco and vape industry actually influenced and successfully halted the GEG. Now, the Deputy Health Minister's remark raises questions about the AG statement that the AGC was believed to be the GEG was unconstitutional. So the government had dropped the GEG provisions which banned tobacco and vape products for anyone born from 2007 from the Control of Smoking Products for Public Health Bill in 2023 when it was tabled in the Dewan Rakyat for first reading on November 28 last year. So I think this exemplifies that there needs to be a lot of political will, there needs to be a lot of advocacy on the ground to actually push to keep our young people safe from the dangers of vaping, because the industry lobby is very heavy and there needs to be a lot of advocacy to push against this strong industry lobby. So with that, I thank you.
Thank you, Prof. Chan. That was a very comprehensive formulation of the case as well as the outline of management. Yeah. So perhaps just a bit briefly, what happened to the patient at present? Yeah.
So the last time we actually had a family session in person with the patient, he appeared well and he definitely denied actually using synthetic cannabinoid vaping at all, but he was still actively nicotine vaping, and he actually rationalized that it will not give him any physical side effects because he's doing a lot of cardio workouts. So he refused the Strattera prescription that we gave him. He refused to take the Strattera that we prescribed him for to control his ADHD symptoms because he felt that there was nothing that was needed to control his ADHD symptoms. If he is not coping well, he just needs to vape nicotine and he'll be fine. So in essence, he's still at the pre-contemplation phase for nicotine vaping.
I remember you mentioned about the narcissistic denial, and that may also pose the continuous challenge in managing this patient as well. Now, my second question is for the benefit of medical students. You mentioned about psychosis that patient presented may also be an indication of a schizophreniform disorder. So maybe how do we differentiate the psychosis in schizophrenia as compared to as presented by this patient, substance use?
Thank you, Prof. Nick, for the very important question. So sometimes at the onset of the presentation of the acute psychosis that is induced by substances, for example, in this case, synthetic cannabinoid, it can be very difficult just based on the positive symptoms to differentiate it from a schizophrenia-like psychosis because they can be very similar. They may even be first-rank Schneiderian symptoms. But what is very important is in the longitudinal history, we have to actually be clear about whether there is any substance use that is temporally and causally related to the psychosis that is presented by the patient. In this patient, it was very clear there was a temporal relationship between the synthetic cannabinoid use as well as the psychosis that was induced. And once he stopped using the synthetic cannabinoids, he was absolutely well from the psychosis. His affect was very well preserved, his cognitive functions were very well preserved, and his function was very well preserved. And the psychosis did not continue after stopping the synthetic cannabinoid use.
Okay, that is very clear. Okay, there is, I just want to add maybe also the telltale signs, the presentation with the visual hallucination, as well as the very acute onset that patient presented with. So another features that may help you to differentiate. Yeah? Okay, I think there is a question from the audience. Emergency medicine, right? Thank you. Okay, that's a very good question. I rephrase, the CT brain, why was it requested during the presentation at emergency department? And second, what was it? How do you differentiate delirium tremens and, okay, and withdrawal in substance use? Okay.
Thank you for the question. I think the CT brain was done acutely because this patient presented with a very acute episode of psychosis. So for the benefit of doubt, whether it is actually an organic cause in the brain, the CT brain was actually done lah. But frankly speaking, a physical examination sometimes may be sufficient if you want to rule out acute organic causes of the brain or other systemic review, as well as blood investigations. But sometimes, for the benefit of the doubt, the CT brain is actually ordered to rule out acute causes of psychosis. Now, I'm really not the expert of substances, but for the sake of the medical students, you need to know that delirium tremens is actually a delirium that occurs maybe 48 to 72 hours after cessation from very chronic alcohol consumption. And in delirium tremens, the patient is in delirium. And so the patient can be psychotic as well, is delirious, meaning that the cognitive functions are impaired. And the patients, typically in textbooks, they will see Lilliputian hallucinations, very small little people as hallucinations. So as Prof. Ning has pointed out, in organic psychosis, visual hallucinations are very prominent. Now, how do you then differentiate it from what you say, the synthetic cannabinoid withdrawal? Now, in this patient, if the acute effects of the synthetic cannabinoid was more of in the intoxication phase, where he presented with the psychosis, where he had visual hallucinations, persecutory delusions, and he purportedly stopped the synthetic cannabinoid vaping about 1 day. So we're not really sure that during presentation, was he presenting more of the acute intoxication symptoms. I think, in my opinion, he was presenting more with the intoxication symptoms and not so much as the withdrawal symptoms. He did show withdrawal symptoms that I think may be more attributed to nicotine vaping, because when he was vaping THC, synthetic THC. We presumably he was not vaping so much of the nicotine, so he was very restless, very irritable, and very aggressive. So it's different from delirium tremens, where the patient's vital signs are going haywire. It can be hypertensive, hypotensive, tachycardic, bradycardic. But having said that, sometimes it can be difficult, as we've mentioned in the presentations. There can be hemodynamic instabilities in synthetic cannabinoid intoxication as well. So I hope that answers the question.
Thank you, Prof. Chan. Is there any other question? We have a few more minutes. Okay, Prof. Fairuz, please. Yeah, thank you, Prof. Fairuz. That's also very, very important to take note, to consider. Are we on? Okay, we are down to the last minute of CPC. So if there is no other question, again, we would like to thank all the presenters for very important discussion, a very informative one as well. Thank you. Thank you. Congratulations.